For long-term ventilation and tracheostomy. Thank you.
Mr. Chairman, dear colleagues, good afternoon. I'd like to thank the organizing and scientific committee for giving me the opportunity to be with you today and talk about this very important topic. So, making the call for long-term ventilation and tracheostomy. It's a big topic, but I will try to discuss it with you, and hopefully we'll have time to discuss at the end of the presentation. So I have no conflict of interest for this presentation. We know that advances in obstetrics and in neonatal care have resulted in an increased survival in extremely preterm infants. However, there are some infants who develop severe bronchopulmonary dysplasia, whatever we do, and may require prolonged respiratory support. I'm sure that all of you, sometimes in your career, had to face lungs like this one, and of course this is going to be a tough job for the neonatologist, particularly when you have to ventilate them. And in fact, some of these infants may fail to win from invasive or non-invasive positive pressure support, and tracheostomy placement for chronic ventilation may become an appropriate option sometimes. However, much controversies remain with respect to the timing of tracheostomy, not only for indication, and the optimal strategies for mechanical ventilation when you got the tracheostomy tube in. And finally, there is no consensus about the appropriate time for weaning mechanical ventilation and tracheostomy the cannulation. It's a tough job. So in the next 25 minutes or so, I would like to touch upon the epidemiology and definition of BPD quite briefly, and talk about the management of long-term ventilatory support in severe BPD, mention about indication and timing of tracheostomy for severe BPD, and I would like to spend a couple of slides about the role of dedicated interdisciplinary teams and the importance to have a discharge plan for ventilator-dependent infants with severe BPD before sending them at home. I realized that I was about 10 when, not 10-year-old, when Northway was publishing this paper mentioning bronchopulmonary dysplasia for the first time. So since at that time, there was a lot of focus about this issue, and this severe chronic lung disease was thought to be associated with a preterm birth and also with the postnatal lung injury due to mechanical ventilation and a high fraction of inspired oxygen. After that, we had to read a lot of several definitions of BPD in the following decades, and the most popular one probably is this one still, published by Professor Job and Eduardo Bancalari many years ago in the Blue Journal. And this is probably the most popular one, but I'm sure that you remember it just to go over quickly on the details of this definition. And patients were subdivided in two groups according to the gestational age, below 32 or equal or more than 32 weeks of gestation. And then another important point was the need for treatment with oxygen more than 20 days, more than 21% more in supplemental oxygen. And then the severity of the BPD was subdivided in three parts: mild, moderate, and severe, and in the two groups. But this is the most popular. But I know Eduardo and Ala for many years, and they are still discussing about how can we rely upon this definition for these babies, and still a lot of controversies about this definition are going on. So we know the bronchopulmonary dysplasia, and by the way, I hope to have some time to show you some brand new data about the definition of bronchopulmonary dysplasia at the end of the talk, hopefully. So we know that BPD is the most common lung disease at childhood after asthma. The incidence is big, Of course, depends on the definition, we know, but roughly we can talk about 2 cases per 1,000 live births. It's more frequent than cystic fibrosis, for instance, and about 20–30% of infants with birth weights less than 1 kilo may develop bronchopulmonary dysplasia. And I'm sure you know also the dispute between new and old BPD. In the past, we had to face a patient like this one with a severe RDS and developing very, very bad lungs, and as we saw in the previous picture. And more progressively, we assisted to a change in the aspects of a chest X-ray of this patient, shifting from this situation to this one. Maybe some patient even not receiving any oxygen at all, any positive pressure at all, and then relentlessly developing some insufficient respiratory insufficiency and oxygen dependence. Of course, we may expect also some intermediate forms nowadays. Traditionally, classic BPD was focusing more on airway injury, parenchymal fibrosis, inflammation, compared to the new BPD, which was focused more on a decreased alveolarization and abnormal microvascularization. But we know that the pathogenesis of bronchopulmonary dysplasia is very, very complex, and this is a nice paper published last year by Higgins and co-workers in the Journal of Pediatrics, showing that there are so many antenatal and postnatal factors interacting and causing the BPD in its various level of severity. Of course, prematurity is the most important factor. A lot of evidence are emphasizing the role, though, of the antenatal origins of BPD, and there are some disruption of the signaling to this baby even during the fetal life, and this may cause a decreased vascular and alveolar growth, eventually reduced surface area, vascular dysfunction, and later respiratory and cardiovascular disease and risk for pulmonary hypertension. Just to give you few numbers about the incidence of BPD and the level of severity. This is a paper published recently by Keller and co-workers, and showing that in this very high-risk cohort of babies with extremely low gestational age, so below 29, if I'm correct, more than 700 babies were studied for this project. And you may appreciate here that in 56% these babies showed no or mild BPD according to the classical definition, and 12, nearly 13% moderate, and about 30% were with severe BPD. But we know that there are very, very different severe BPDs out there. There are some preterm infants who will steadily improve and will tolerate a gradual weaning or respiratory support within the NICU. Other will clearly, conversely, will clearly develop a chronic respiratory failure, as demonstrated by failed attempts to wean mechanical ventilation, and this patient will remain intubated, requiring tracheostomy in some cases. The problem is that because of the low incidence of most severe BPD cases at any single center, this population still remains under study, and many gaps in knowledge and controversies exist regarding the optimal clinical strategies to improve outcomes in this complex subgroup of infants. Just to give you an example, how should we ventilate this patient? And this is a paper published a couple of years ago by Stephen Abelman and co-workers from the Colorado group, and they were just showing a lot of interesting details in their patient. And this is to show that in the left part, this is the chest X-ray of a severe BPD baby, and you may appreciate the tracheostomy cannula here. And this is the CT scan, which illustrates the severity of the condition of the lungs. How should we ventilate these babies? So traditionally, when we are dealing in the early phase with these babies, we are trying to be protective. So we are using strategies to prevent acute lung injury, So you're using low tidal volume. We heard very nicely by Professor Luna a lot of important information earlier on. So we are using low tidal volumes, short inspiratory times, increased PEEP for lung recruitment, without trying to not overextend the baby, the lungs of the baby. And also the strategies for gas exchanges. We adjust the FiO2 to maintain SpO2 in the range of 91 to 95%, and permissive hypercapnia could be considered. But as time passes, you must realize that maybe this kind of parameters may become obsolete, and you have to shift in your strategy, maybe changing the tidal volume, using larger tidal volumes, using longer inspiratory times, and try to deal with the airway obstructions, and try to use the PEEP. Sometimes because of dynamic collapse of the airway, you can expect some tracheomalacia or bronchomalacia in these patients. So let's have a look to this cartoon. If you got an established severe BPD and you are trying to ventilate this baby with low tidal volume and short inspiratory times, what could happen? The lungs is pretty unhomogeneous. It's very different. You may expect zones with the normal compliance and normal resistance, low compliance and high resistance, high compliance, low resistance, normal compliance and high resistance. Okay. So if you are using small volumes, this small volume and short inspiratory time, the vast majority of the volume is going to go in the easiest part. Is not clever in the ventilator. Is just pushing air, and the air is going to the easiest place to go. So they are just occupying this part. All the rest of the lungs, you may expect some progressive atelectasis, some regional overdistension maybe, and in short, you may expect a worse distribution of gas and increased dead space ventilation. Instead, if you are using high tidal volume and longer inspiratory time, you are allowing air to reach other zones of the lungs. So you may improve the gas distribution, you may decrease the ratio between the dead space and the tidal volume, lower the CO2, lower the FiO2, and less atelectasis. And also there are other babies, intermediate babies, so-called, who are medically stable even after the extubation, but they go on develop marked respiratory distress and dependence on non-invasive support, CPAP or synchronized non-invasive ventilation, high-flow nasal cannula, which are very, very trendy nowadays. In fact, these infants warrant consideration of tracheostomy for chronic ventilation sometimes, and particularly when there are some other cofactors, for instance, tracheobronchomalacia, which may increase the likelihood that the infant will benefit from tracheostomy and before being discharged with chronic ventilation. But what about the timing of tracheostomy? The decision to put in place a tracheocannula in these severe BPD babies to start a chronic ventilatory support is not easy at all. It's very complex and difficult most of the times, and requires extensive discussions among care providers and family members. It's always a very, very difficult decision. Many factors may contribute to the decision, even though the overall goal of the chronic ventilatory support is to reduce the severity of respiratory distress, including the spells crisis of this baby, for instance, to provide clinical stability that will enhance survival and optimize long-term developmental, neurocognitive, and growth-related outcomes. But there is a question at this point. When is prolonged mechanic ventilation long enough to prompt tracheostomy in children? And I think that this is still an unanswered question. Let me give you this example. This is an interesting study published by Marty and co-workers a couple of years ago in the Journal of Perinatology. And this was an intercenter variation in data on tracheostomy placement in infants with severe bronchopulmonary dysplasia. And the objective of this paper was to estimate the presence and sources of intercenter variation in the risk of death or tracheostomy placement among infants with severe bronchopulmonary dysplasia. So this was a consortium of many hospitals in North America. And you may appreciate here that in the y-axis you got the proportion of infants with death or tracheostomy, so what a composite outcome. On the x-axis, the different centers. So you may appreciate the variability here in this cartoon, which ranges from 2 up to 47%. We are talking about, a fairly homogeneous area, big hospital in the North America, okay? And another important thing is that when you are just picking up tracheostomy placement only, the range of variation was from 2 to 37%. Was really striking in my opinion. So how the decisions are made in different centers, we don't really know. And just to give you this number, this is a very recent paper published by Kurata et al. In Japan, working in Japan on pediatric pulmonology this year. So they had a huge database. It's not so detailed as a database, but it's really huge. They look at more than 34,000 babies, very low birth weight infants, and only 0.93% underwent tracheostomy from 2003 and 2012. So a huge difference between different centers and different countries. So probably we should take advantage of some predictive tools maybe, or some biomarkers or some other system to guide us in taking such a decision. But what we got out there, not much actually up to now. I'd like to show you this paper published a couple of years ago by Catherine Way and co-workers, and they put this question on the table. What are the clinical indicators for tracheotomy in extremely low gestational age newborns below 29 weeks of gestation? So what they found, I have no time to go into much details in this paper, but you may see the reference over here. So they found that in this secondary analysis of a randomized clinical trials of more than 500 high-risk patients, 15 infants underwent tracheostomy, and the mean age of tracheotomy was 126 days. Interestingly, mean airway pressure declined in the no tracheotomy group, whereas it increased in the tracheotomy group, with a divergence occurring several weeks before the infants underwent tracheostomy. So maybe you may appreciate this in this figure better. So again, the y-axis mean airway pressure, x-axis age in days. And you may appreciate here the yellow line is a positive pressure group with no tracheotomy, and in the blue line is the mean airway pressure in the group where subjects were eventually treated with tracheotomy. So there was some difference in very early. Maybe we could have picked up this one to take some decision or to get some clues before taking any decision. We will see. We need, of course, more study to validate this preliminary observation, but certainly this paper is just pointing out that by looking at the mean airway pressure trends, we can have some guide in taking our decision about airway evaluation tracheotomy in these very high-risk patients. Let me mention the role of dedicated people to these very tough patients. So this is an experience from the Colorado group, and they were just reporting their retrospective experience of the interdisciplinary ventilator care program intervention on survival of infants with ventilator-dependent bronchopulmonary dysplasia. So you may see here the ventilator care program interdisciplinary team is composed by many different professionals. All of them are very important though. And the impact of survivals in two different epochs before and after the implementation of this ventilating care program, you may appreciate, was really something, because we are talking about, of course, about a few patients, not that many. I have to emphasize this. You may appreciate that survival increased from 50% to 85% since the activity of this ventilator care program was established. Another consideration important to me is that before sending home this patient, we should have a standardized discharge process, which could be helpful not only once the baby is at home, but before getting home, probably shortening the length of stay, for instance, for this kind of patient. And this is a paper published in Pediatrics in 2016, again from the Colorado group. And let me just show you this part of the results. So the primary outcomes was overall hospital length of stay, which was reduced from 249 days to 143 after the implementation of standardized discharge process. The patient respiratory care unit length of stay was reduced halved, more than halved. The secondary outcomes, tracheostomy placement to discharge, 197 down to 116. So really an impact, a very, very important impact in my opinion by implementing this standardized discharge process. And this is a cartoon, just of course not to be read, but just to show you the complexity of the process that they were able to build on. So starting from the very first evaluation going on with the tracheal surgery, and then training the people, training the family, training the nurses that will have to take care of this baby once at home, and finally the baby reaching home, sweet home. Okay, so very complex process, a very complex pathway, but probably by looking at their results, probably is worth it. I promised to show you some brand new data about the definition of bronchopulmonary dysplasia. This is a paper which was published 3 days ago in the Blue Journal. So, diagnosis of bronchopulmonary dysplasia in very preterm infants. I'd like to show you first the rationale of the study. And the rationale was that the current diagnostic, according to these authors, the current diagnostic criteria for bronchopulmonary dysplasia rely heavily on the level and duration of oxygen therapy, and do not reflect contemporary neonatal care, and do not adequately predict childhood morbidity. In terms of do not reflect contemporary neonatal care, probably they were alluding to the fact, for instance, that we are using more and more high-flow nasal cannula, which was not contemplated in previous definitions. So the objective of the study was to determine which of 18 pre-specified revised definition of BPD that variably define disease severity according to the level of respiratory support and supplemental oxygen administered at 36 weeks post-menstrual age best predicts that of serious respiratory morbidity through 18-26 months corrected age. So I have no time to go into many details here, but just to show you the cohort they studied, there were more than 2,600 babies, tiny ones. You see the mean gestational age of 25, the birth weight 765, and the outcome. The outcome overall was late death or serious respiratory morbidity of in 26%, and late death or moderate or severe neurodevelopmental impairment at 49. What they were able to find was a definition which was able, offering a model to identify correctly most of these patients by grouping the babies, by subdividing babies in 4 groups. No BPD, grade 1. Grade 1 means nasal cannula with a flow of oxygen less than 2 liters per minute. Grade 2, nasal cannula or non-invasive support and nasal cannula with a flow of oxygen more than 2 liters per minute. Grade 3, invasive mechanical ventilation. And in most cases, they were able to correctly identify. You may see here late death and serious respiratory morbidity in the grade 3, the worst in worst scenario, in the grade 3, the most sick, the sickest ones, 77%. And tracheostomy, you may see hardly absent here, hardly present here, and 0.7, 5, and jumping up to 31% in the sickest group. So the conclusion of this paper is that the definition of bronchopulmonary dysplasia that best predicted early childhood morbidity categorized disease severity according to the mode of respiratory support administered at 36 weeks of postmenstrual age, and most importantly, regardless of supplemental oxygen use. This is the revolution, in my opinion. So we'll see in the future if this data will be validated and confirmed by other groups. I'd like to end with this paper, which I recommend you if you are interested in this topic, because I mean this subject is very, very vast, and I couldn't really touch upon too many interesting things. For instance, the to track or not to track in case of ethical dilemmas, for instance. We cannot cover this part right now. I'm happy to talk about this in the discussion if you like. But if you like to have a nice and complete overview of the subject, please have a look to this nice paper published quite recently. So in conclusion, I think that the future research should be aimed at determining optimal patient selection and timing for tracheostomy placement in infants with severe BPD. Earlier infant tracheostomy may facilitate weaning, decrease the need for pharmacologic sedation, allowing the infant to engage in developmental appropriate activities, including play, feeding, and vocalization, thus improving cognitive and motor outcomes. But of course, additional studies are needed to confirm that these benefits outweigh the possible risk of early tracheostomy. Thank you for your attention.